Hello everyone, welcome to this CCAN webinar. On behalf of CCAN of City Cancer Challenge, I'd like to thank you very much for joining us. We are very glad and very proud to have such a broad audience for this webinar. You were almost 500 to register for the event, which is, I believe, a record number in the story of CCAN. So thank you very much for your attention and for your participation. My name is Harold Cotin. I'm head of Global Public Affairs for City Cancer Challenge, and I will be your host today. The objective of this webinar is to share with you the budget impact analysis that has been developed by City Cancer Challenge with local stakeholders to analyze the budget impact of the inclusion of cancer diagnostics in UHC packages. We'll start, as you can see on the slide, with a presentation of the tool itself, and then we will describe its test implementation in one of our cities, Tbilisi in Georgia. As you can see, we'll have the time for a Q&A, so please don't hesitate to use the Q&A feature offered by Zoom, so to share your questions in writing in the chat, and we will make sure we will share it with the audience and with our speakers. Please take note that this webinar is recorded and that we also have an automatic translation into Spanish. Steph, if you want to have a special attention to our Spanish-speaking colleagues.
Gracias, buenos días y buenas tardes a todos. Para traducciones en español, por favor, solo presione el botón Interpretación abajo y selecciona la opción Español. También escribiré en el chat. Y cualquier duda pueden escribir en el chat.
Muchas gracias, Steph. Thank you very much and merci beaucoup. I will now start and pass the floor to my colleague, Alfredo, who is our Director of Technical Cooperation and Capacity Development at City Cancer Challenge, so that Alfredo can set the scene. Alfredo, the floor is yours.
Thank you, Harold. And let me echo your words and to thank all the participants. There is always a very competitive events agenda, no? So there are events all over the place all the time. So having such a big participation in today's event is really for CCAN a pleasure, and we thank you very much for this. We are presenting a very concrete thing, a tool, but let me frame a little bit before going into the presentation of the tool, where we are and what CCAN does, and how this tool can be framed into the work, the broad work that CCAN does. This is what brings everybody here today, no? Talking about this tool, the budget impact analysis, the model to calculate the budget impact analysis. But this is also a good reflection beyond the tool itself. It's a good reflection on how CCAN works, because the tool that you will see later started in one of our cities in Tbilisi, Georgia, at the moment where the national government was exploring reimbursement of cancer diagnosis. And then we soon have seen the relevance and how this can be transferred, the approach can be transferred to other cities. So as a cross-city product, we have developed a generic model for calculating budget impact analysis for reimbursement of diagnostics from a payer perspective. But in addition to this cross-city application, the tool that we are presenting helps to also illuminate a broader global issue. And we have tried to reflect in this slide. And this is how often evidence is disconnected from actual decisions and to policies that enable funding and financing interventions. So for example, here we have seen many times on the left hand, we have seen many times that we try to incorporate interventions that are cost effective, only because they are cost effective. Without any other assessment, we have proven that those interventions many times, most of the times, are not sustainable. But also on the right-hand side, we have seen many times interventions that are included in a benefit package for political reasons that haven't proven that they bring value for money to the cancer care. So this is the spectrum that we are trying to really reconcile with this budget impact analysis. And this is becoming more and more best practice in economic assessment. We have to prove, yes, that the intervention is cost effective and may even add value for money. But we need to also assess how much this is going to impact, how much money this is going to cost for the city or for the country. And only the combination of this assessment will be informing policy decisions on what to fund and how to finance the scale up of these services. So this is the setting for this meeting today, and this is where we want to frame this tool. It's at the three levels, no? It is at the city level, it is also at the cross-city level, and it's also how this can inform a global dialogue or a global consultation on how to fund and finance, in this particular case, diagnostic services. So again, I thank you very much for being here today with us, and I would like to pass the floor back to my colleague Harold to continue the conversation. Thank you.
Thank you very much, Alfredo, for those introduction remarks, very wise. I'd like to turn towards now my other colleague, Michael Gorn, who is the lead for health financing within City Council Challenge, so that Michael can introduce the tool itself to the audience. Michael, over to you.
Okay, thank you, Harold. So I'll take you through the tool, just taking us through how the tool was developed and how this is relevant to the current health financing priorities that most of the cities need to be solving. So as you're aware, a budget impact analysis estimates the financial consequences of a payer adopting new healthcare technologies, and we find that they are an essential part of the comprehensive economic assessment of a healthcare intervention, as Alfredo has described. And it's used by various payers, including other policymakers, to make some of these reimbursement decisions. And as you can see, the primary purpose of the BIA will estimate how much resources, are needed to implement some of these interventions, and also the impact on resource consumption, and also provides solutions that could be used for policy and budget planning, and also inform other aspects of economic assessments such as affordability assessment, and lastly, also support evidence-based decision making that will support resource allocation to areas where we need to prioritize, getting certain outcomes. So as you can see, the key elements of BIA, as you can see, there's the size of the population that we need to consider, and the mix of interventions and expected mix after we have adopted this new intervention. Then what is also the cost of these intervention mixes? And lastly, any changes that are expected in some of these condition-related costs. So for the key steps, as you can see, that we'll now go through, we have 6 key steps that I will take you through from the next slide. And as you can see, the first one is on the needs assessment and stakeholder consultation, where we need to identify some of these gaps in treatment or diagnosis and consult various stakeholders, so as we are able to define the model scope and the objectives that we aim to achieve once we have adopted this kind of model. So many reasons can be given for adopting such a model, from low coverage of diagnostics within the city, availability of resources to support the same, and others also a concurrent high demand of these services, which will necessitate us to try and estimate the resources that will be needed to adopt such a model. So we can do certain assessments to understand the burden of cancer within the given locality, and also review existing data on the coverage by this UHC scheme or pair to understand the gaps in coverage that we need to address by trying to adopt this new model. We can also have consultative sessions with stakeholders. And what I would like to emphasize is that it needs to be a multi-stakeholder approach, bringing everyone on board, from those involved in the treatments, the patient themselves, so that all of their needs should be captured to ensure that the model itself addresses their needs. And we also have to document the gaps in coverage, be it diagnosis or treatments, once these have been identified. And we also need to understand whether the modeling exercise that we are currently implementing will be required to unlock additional financial coverage for diagnostics, to ensure that, yes, we are starting from somewhere where we are estimating the gaps in terms of diagnosis coverage, but we need to know how much resources will be needed. And once we have this model, will it be able to unlock additional resources based on the evidence that would have been generated from this? Then next, we need to, which is the second step, we need to look at how to develop some of these diagnostic packages. So as you are all aware, cancer is a complex disease with so many interventions going into diagnosing and treating it. So we have to develop various packages based on our goal of improving coverage. And this may also depend on the resources that are available, and we could be able to develop this in various tiers. So there are various guidelines that could be used in areas where we have local treatment guidelines that are available. These could be used to inform the tests that will be needed to ensure that diagnosis is well covered. Or in cases where these are not available, we could explore using other international guidelines like the NCCN, which could be able to inform the tests that will be needed during this process. So the main goal here is to ensure that the guidelines are aligned with the actual practices, so that to try and simulate a real world scenario, in that we do not want a situation where the guidelines say one thing, but the actual treatment within the facilities is different. So we are trying to simulate a real world scenario to ensure that the estimates that we get from the model more or less simulate the real scenario of treatment, so as to be able to estimate the costs that will be incurred as a result. So we could have tiered packages, and there could be more than two, but in our case, we decided to look at two, where one, we consider the essential package, which is basically the test that will be needed to make a diagnosis. And next is the comprehensive, or rather the extended package, that these are the tests that will be needed in addition to the basic package to inform the correct treatment. So after we've developed the diagnostic packages, the next stage will be looking at the pricing data. And in this case, we are trying to understand the providers within this area where we are considering how much do they charge for these services. So just to mention that in fully public system, we will focus on the cost data. And the cost, it will mean the cost of offering that service, meaning that we might need to do a costing activity to ensure that we are able to estimate these costs. But in a private system where providers are contracted to offer service, then pricing data will be used to inform what will be the basis of our model. So to ensure that the model will be generalized across different payment framework, we need to ensure that these costs or pricing data are collected from a representative sample of facilities which we would expect to offer this service. So it wouldn't make sense to collect this data from facilities that wouldn't offer the service, because it would be misleading. So we have to ensure that this reflects the real world scenario. And to ensure that this data is actually what's needed, we need to ensure that the process is validated, and the data that's collected will have input from experts to ensure that it is it is relevant for this particular exercise. And to make also the tool more realistic and responding to real world demands, we have to ensure that we use weighted averages based on the number of patients each facility is expected to offer, or rather to cater for, once we've already implemented this model. And this will mean either estimating the capacity of the facilities to offer this service, or relying on historical data that basically looks at the trends in terms of the patient numbers that have been attended to in this facility. So once we've done all this, then our final product for this step will be a database that will be summarizing the prices of all these diagnostic services. And this one will now take us to the next step. As you can see, we have the sample pricing data for breast cancer, and it will basically list all the services that will be needed to correctly diagnose breast cancer, though this does not list all of them. And we'll get pricing from various facilities based on what we described in the previous slide. And also, as you can see, next, as I'll explain later, we'll see the number of forecasted cancer cases that will be entered into this form to be able to know what we are focusing or what we are forecasting going into the future. So once we have all this data in terms of the treatment plans that are there, the tests that are supposed to be performed, and their pricing data, we need now to proceed into building the model. And as I mentioned earlier, this is where we look at the population that will be covered by such a package. So what we need to do is to forecast the incidence rates for each of the cancers to be considered, and this could be obtained from the local cancer registries or from other, other databases that could be able to correctly forecast the cases we have. So the forecasting period could be over 5 or 10 years, depending on what the system requires at such a step. So also, to ensure that the degree of coverage aligned to the 3 dimensions of UHC, we need to consider the proportion of the population that will be covered by such an intervention, given that because of resource constraints, at times we are not able to cover the entire population. Then we also need to look at the range of services that will be covered, also will be based on priority or resource considerations. And lastly, we need to look at the cost coverage. So in this case, we need to consider what will be covered by the payer and what will be covered by the patient, and this will inform the budget that will be set aside. So also, after this, then we should be able to have a total budget model that includes each cancer separately and also for the entire package. So as you can see here, we have a sample budget sheet for cervical cancer. And as you can see, the various services have been labeled as either basic, or rather the essential package, or full or the comprehensive package, and whether these will be included within the package. You can see the number of cases that are expected to receive this service. We can always talk about, let's say, 100% of the patients are expected to receive the service, but we could also look at various factors such as the number of patients proceeding from screening to diagnosis and all that, to be able to correctly estimate those who are expected to receive the service. So next, after we've done all this, we need to move to the case where we're looking at the scenario and sensitivity analysis. So on the scenario analysis part, we need to look at the structural assumptions in this model, and this will basically look at the various scenarios that we may adopt for this particular model, such as I mentioned previously, the choice of the packages would either be a basic or a comprehensive package. We could look at the coverage rate of the population, as we mentioned, the population that's expected to benefit from these new diagnostic packages being included within the model, and any co-financing arrangements, that is the cost part, that will evaluate the budgetary impact of alternative policy choices. Then on the sensitivity analysis, we need to look at how robust the model is, to kind of cater for certain uncertainties within the various parameters. So we will systematically vary these parameters and to assess how much they will influence the overall budget estimates that we are considering. So we need to explore, for example, the impact of pricing uncertainty on the total annual expenditures. How could we be able to do this? Are we able to factor in, let's say, changes in pricing, medical inflation, and things like that? Or in other cases, are we able to examine also the changes in the cost sharing agreements? If, for example, at a certain point in time, there's less resources that have been allocated for this program, then we need to consider, do we increase the level of the co-payments that are payable by the patients? Or if there are more resources, will the government increase the resources that are available in this particular situation? So to finish up, as you can see, this is the sample sheet for the total budget of all cancers. We can see all the cancer types and whether they are included within the budget, and the basic or the comprehensive budget that will be for these particular years. It could be up to 5 to 10 years, depending on how well we're able to forecast some of these costs. So other parameters that we might look at, as I mentioned earlier, the percentage of cases being covered, the price indicators. What price indicators are we using? Is it the average? Is it the weighted average? Are we using the median? Are we using other percentiles, such as the 25th percentiles, to more or less mirror what are our priorities as a pair? Then also look at the price increase and inflation, as I mentioned previously, and also the percentage of budget that will be covered by the government or any other payer. So once we've done all this, we've collected all the data, the pricing data, built our model, incorporated the populations that will be factored in. Then the next thing, then the outputs of this process will be a model that will guide the standard diagnostic procedures for cancer according to the national and international guidelines. Then we will also have a report on the multiple scenarios of budget impact forecast for the inclusion of diagnostic reimbursement. And we'll also have an overall budget impact for all cancers based on the above analysis and scenarios. And based on this model and based on our estimation of the resources, then we are able to provide certain recommendations to the Ministry of Health or any other payer on the steps to take forward to ensure implementation of the same. So we've developed a model, and based on our experience in Tbilisi, which will be covered by Nino, we realized that there are certain areas that we would focus on to ensure that the model is more foolproof. So the current model that we have, in that we have been trying to simulate various scenarios, but so far the current model does not simulate repeat visits. And in this case, it will be a situation where the initial tests were carried out, but there are certain tests that need to be repeated. So maybe we could work with a factor to kind of try to estimate the cost of this. And this also includes tests for monitoring treatment, in that once a patient has gone through a treatment cycle, then certain diagnostic tests may be needed to follow up on the progress of treatment. Then also in our model, we had the basic and comprehensive packages, but in certain scenarios, we might have tests that I would call lying in the middle of the basic and comprehensive packages. So these have not been factored in the model. So we only factored these two scenarios of having a basic and a comprehensive model. Then next, we have the pricing. So we use the average pricing in this model, but as we mentioned earlier, a weighted average pricing based on the number of patients expected to be seen by the providers will be more accurate. And lastly, and this is quite pertinent, the case mix of the various cancers was not considered here. And this, for example, we consider that all patients will be starting from a given cancer staging. But in reality, we know that there are patients who will be diagnosed as stage 1, other stage 2, other stage 3. And based on this, the various needs in terms of diagnosis will differ. So if we could be able to model around this to ensure that we're able to simulate these various case mixes, then we could get a more, I'll say, robust model that could respond to the real world needs. Guys, thank you. I'll hand over to Harold.
Thank you very much, Michael. I'd like to recall you, please feel free to share your questions in writing in the chat, and we'll take them during the Q&A sessions that will come after the next presentation. So thank you again, Michael. Now I'd like to turn towards my colleague Natia Verdzadze, who is BDC project manager and GBCI project manager, so that she can tell us about the way this tool has been implemented and tested in the context of BDC in Georgia. And Natia will come with Nino Chokolakashvili, sorry for the pronunciation, who was the project coordinator together with Natia. Natia, Nino, the floor is yours.
Thank you, Harold. So I will start with the general experience sharing from Tbilisi, and then Nino will continue with the specific experience on this project. So the Tbilisi's journey with City Cancer Challenge started from 2019 through the Memorandum of Understanding with the Ministry of Health, Tbilisi City Hall, and patient organization. And since then, the city has undergone the transformative journey, starting with stakeholder mapping and a comprehensive needs assessment, followed by the formation of local committees that prioritized urgent gaps and mobilized action. One of the first major outcomes was the government's 2019 decision to expand the list of the cancer medicines under the Universal Healthcare Program and to raise the annual limit. And it was the early sign of strong local commitment. A city executive committee, including high-level public health leaders and cancer experts, was launched in 2020 to guide and monitor project implementation. Based on the local priorities, multidisciplinary project teams were formed to address key areas such as cancer education, registry systems, diagnostic services, quality care. And for example, a new in-hospital pharmacy model was introduced to improve systemic treatment safety as an immediate win that was adopted nationally. Among our key achievements are universal healthcare programs expanded the coverage for cancer medicines, which I already mentioned, in-hospital oncopharmacy establishment, the breast cancer action plan for Tbilisi, cancer management guidelines, which were adopted to the local needs, and development of the electronic module for primary healthcare doctors. And beyond these projects, Tbilisi benefited from impactful capacity development activities, such as international training, scientific visits, collaborations with WHO, ESCO, Catalan Oncology Center, and many others. First Global Breast Cancer Initiative workshop, all reinforcing cancer care excellence and leadership development, including among women oncologists. And now with the launch of the Cycle 2, which was informed by the Global Breast Cancer Initiative workshop and scoping visits, Tbilisi is focusing on 3 thematic areas: improving early diagnostics, ensuring quality and timely diagnostics, and enhancing cancer care standards. As we move forward, Tbilisi's experience offers a powerful example of how locally driven, globally supported collaboration can deliver real impact. The Cancer Diagnostic Reimbursement Project was one of the successfully implemented projects from the Tbilisi Cycle 1 Technical Cooperation Program, which was requested by the Ministry of Health. And with this information, I would like to stop as Nino will be presenting details of this project. Thank you.
Thank you, Natia. Just before Nino takes the floor, we have a comment saying that the slides are not visible. Is it the case for everyone? No, you can see the slides? Okay. Let's see if we need to fix it. Nino, can
Yes,
you?
I can see the slides, yes.
Okay, so please go ahead. Thank you, Nino.
Thank you very much. It's my pleasure to participate in the meeting today and especially to be the part of this very important project for Georgia. Just to give you a bit more background information why this project was very important and strategic for the country. We have a growing number of cases of cancer in the country, and also the local healthcare system provider is say expensive for the average population to cover the cost of the diagnostic services, which very often leads to the late diagnostics of cancer in the country and obviously affects the fatality rate in the country. This is why was very important and essential for Ministry of Health to understand what will be role of the ministry in supporting the early diagnostic of cancer in the country. In this regards, ministry requested, as mentioned earlier, SICAN to support in understanding the budget that it would cost ministry to finance the early cancer diagnostics through the universal healthcare system in Georgia. To give you a bit more context on the Georgian healthcare system, the main healthcare providers in the country is private sector. So all clinics are privately owned. They develop their own pricing systems, and there is certain areas of the treatments that is financed through the universal healthcare system, funded by the government for the whole population of the Georgia. So it was important to understand what would be the total budget of including the cancer diagnostic as part of the universal healthcare system, which was not, let's say, available to the general population. So the main goal and task of the project was to understand the overall costs to the government in case of including this treatment and diagnostics in the healthcare package. So the first part of the task was to understand what are the main services that need to be provided to the population. And obviously, these types of services differ by cancer types. So first, at the first stage, we developed the packages of services for each cancer type. At the second stage, we understand what is the pricing of such services on the local market currently. And in the stage 3, we did the budget forecast to understand what would be the cost of each of the services and each of the packages, depending on the cancer type. The last stage of the project was to give this feedback to the ministry and help them understand what will be the 10-year forecast for including the packages into the universal healthcare system. So this is the broad, let's say, background to the project, and I will go through the each stage separately. One important part to consider in terms of the background of the project is also that this was not intending as, let's say, pricing exercise. So the current prices of the local service providers were used as basis for the estimating the budget. So as I mentioned, the first stage was dedicated to developing the cancer packages, service packages for each cancer type. As Michael mentioned during his presentation, the combination of local and international guidelines were used to develop the package. And here it was important to use the most, let's say, advanced services that are provided globally and recommended by international guidelines. And of course, to match it with the local services that are provided in the market in Georgia and ensure that these services are available in Georgia. We use the combination of these two, let's say, guidelines. And a very important part of the project was to include the medical experts on the market. Here, the ministry supported the project with, let's say, providing the panel of the experts, of the highly experienced healthcare providers on the market, oncology experts, who provided, let's say, inputs and insights into the different types of cancers, which was their specialization. And they helped develop the final packages of the for each types of cancer locally. So that's covered the first task of the project. So we, in the end of this task, had the each package included the services that are unique to Georgia that will be actually used by healthcare providers and by ministry to estimate what types of services need to be provided. If we move to the next stage. So once we have developed an understanding of what are the services we need to provide, then it was important to understand how much these services will cost on the market. Here, as a step one, we selected the, let's say, clinics on the local market that provide the most or all of the services required for these packages. And obviously the selection also included the filter for the reputation of the local companies. And with them, we tested the list of services, because obviously it is important at this stage to understand that the list of the services that we have developed matches this list of, let's say, names and services that they provide. So here it is important to ensure that we are speaking on the same language, to understand that the prices that we collect will be, let's say, the correct prices for correct services that we have designed. So here we conducted the, let's say, interviews with all of the healthcare providers. We ensured that they understand the pricing that we requested from them. And once we collected all this information, we ensured that the prices are not drastically different from each other. If there were any important differences, we went back to the clinics to ensure that we received the price for the correct service that were, let's say, same for all the healthcare providers. And all this information helped us develop the database of prices for all health services that were in the packages. So if we move to the next stage. So once we had the prices for all stages, it was important to understand how much of each service will be used by the local population. So here we relied on the information obtained from the Global Cancer Observatory, which predicts the number of cases for each country, specifically for Georgia in this case, for each cancer type. And based on their forecast, we estimated how many patients might require such service in Georgia, and designed the, let's say, a budget according to their estimate. So this was the important input into the model. And here also, when the data was not available, we obviously used the interpolation method to ensure that we have the estimates for each year. And as I mentioned earlier, the budget was prepared for 10 years in total. One more important factor here that we also discussed with ministry is that there is a forecast for a number of cases, but obviously not all patients who will receive diagnosis will be diagnosed with cancer. So in this case, it's important to understand for the, let's say, implementing entity, in this case, what will be the let's say, appropriate overestimation of the forecast for the implementer to ensure that enough patients get the diagnostics services on the in the country. With all this data, obviously, we designed the final model. And if we move to the next stage. So where obviously the model is very large, will not show the full model, but to give you the understanding. So as Michael already described, so we together with the ministry decided what was the number of percentage of incidence we will use for the forecast. So in this case, it's mentioned it's 150%, which means that if there is 1,000 patients predicted to have cancer identified, for example, breast cancer, we will use an overestimation. So 1,500 patients will be eligible to receive diagnostic services on average. Then we use, in this case, it's just for example, we use the average prices. So obviously there is a different prices provided by different healthcare providers. So here it is important for the implementer to understand whether they want to use the minimal prices, average prices, or will focus more on the higher quality services and have the higher, let's say, price estimate in mind. Next, obviously, the prices increase, so we cannot keep the prices steady over the 10-year forecast. So in this case, we use the average inflation rate, which is relevant for Georgia. In this case, it was at this that time about 4%. So we increased prices that we collected by average 4% each year for the 10-year forecast. And the last part, which is also very important, is to understand what portion of the service will be covered by the implementer. So depending on the structure of the country, it can be 100%, 50%. So it really depends on the implementer, what share of this cost they want to cover in terms of the budget. Then just to give one more point on this slide. So also as Michael described, so there is different ways we can look at the budget. So one way is to look only at the basic services, the most critical services that will cover for the patients. So here we use the basic package estimate. Also, if implementer will decide to include, let's say, all type of services for all cancer types, then we can use the full budget. And the combination is really what we believe we should be looking at, which means that for patients that get the, let's say, diagnostics at the early stage, they should receive the full package, and the patients that will be, let's say, screened at the initial stage of the diagnostics will receive only the basic package. So this gives us the combination budget, which is something in between of the basic and full package. And if we move to the next slide. And here, this is just an example of the larynx cancer. So here you see the, let's say, the initial assumptions we use. What is the price of each type of cancer? In this case, larynx cancer type for basic package and full package. And in the model, it is important to give the implementer the tool to, let's say, play with the numbers based on what is the budget affordability of the implementer. Here we have the prices for different services, in this case, larynx cancer. So what is the average price of these treatments today in Georgia? Will it be part of the basic or full package? Will government decide to use all this, include all these services in the package? Here it is important that certain services are very costly. So implementer might decide to exclude certain types of services. Then what is the incident rate? So because there is a different types of subtypes of cancers, it's important to understand together with healthcare providers. So how often this type of service will be required for patients, and what portion of the patients can receive this treatment. So this concludes the main parts of the model. And if we move to the last slide, just some important points that we identified when discussing this, let's say, model with the implementer to take it forward and implement this, let's say, diagnostic package in the country. One very important step is to understand who is eligible. So what types of pre-screening tests will enable a patient to receive the, let's say, access to this healthcare packages. Next one is the quality control part, because if the implementer decides to focus on the low prices, which usually is the, let's say, route that governments use to save costs, it's important here to ensure that the quality is monitored of the healthcare providers that will be included in the system. Next, it is important to verify the prices of the private sector, because on one side, obviously, budget is important to the implementer, in this case, government. On the other side, the private sector usually has a tendency to overprice the services to ensure that, let's say, maximum revenue is reached. So in this case, it is important to have a tool to monitor the prices and ensure that they are realistic and aligned with the country's, let's say, current services. And finally, one of the most important parts where the experts' input is critical is to determine the algorithm how these services will be prescribed. Obviously, if there is 10 services, for example, in the larynx cancer, it is important for the government to ensure the tools and the algorithms that not all services will be used if they're not necessary, right? So here deciding on what service will be provided first and how these next services will be decided, this is very important part. So this concludes the presentation, and obviously I'm available for questions. Thank you very much.
Thank you so much, Nino. Thank you very much, Natia, too. So as you said, we can now go to the interactive segment, the Q&A session. Thank you very much for the huge amount of questions that you shared in the Q&A. We already answered some of them in writing, but we kept some of them for this Q&A session, and so that we can answer them directly orally with our experts. Maybe I will start with the first one from Duncan. Duncan, thank you very much for your many questions and your comments. I'd like to start with one of the questions that you shared, your recommendations to focus down and make impact in smaller areas. So you mentioned the option to focus on one hospital or one region, also the option to focus on 2 or 3 priority cancer types to make the implementation of the tool meaningful and impactful. I like to share these questions with our experts from SICAN. Alfredo, Michael, can you address that question?
Yes, I'll address the question. So what we considered was the payer perspective, that is from the perspective of the Ministry of Health, Georgia. So the Ministry of Health, Georgia, wanted a model that could estimate the resources that will be needed to offer some level of tiered coverage for cancer care. So it meant that based on that mandate, we had to consider all hospitals and the entire region and all cancers. And this was given as a result of the healthcare system currently not having adequate coverage for diagnosis. Sorry, for the diagnostics. But as we've also mentioned that we could create certain budget impact assessment that could mirror what could be done at the facility level. And I guess you're talking about the costing of these services at such a level. I think that could be done. And so what you're trying to do is now the budget impact. But also, as we mentioned, as Alfred had mentioned earlier, we could also consider certain aspects such as the cost effect or the cost benefit analysis, which in this situation were not adequate for the government. So the priority was on the total impact to the budget, and if the government had those resources available to be able to respond to this need. So that is why we looked at it from a national perspective and from the entire region and all cancers being considered. Thank you.
Thank you, Michael. Alfredo, I see you want to add something.
Yes, no, just to complement what Michael have said, and the model is just a model, so you can really change the scope, change the perspective for the model. I mean, more than a model is a methodology to create your own model, no? So if you take into consideration all the steps that we have been describing, and that will be available with the document that will be released, Duncan, you can do exactly what you said, no? Maybe instead of pricing, you need costing. And rather than going broad, you go into one region, one city, one facility, one or two priority cancer types. So what we present is a methodology to create your own model. So you can test your assumptions and you can validate the model in this local context. I think this is the beauty, if you want, of this methodology. Thank you.
Thank you. I like to share another question. Duncan, I will come back to your questions, but I'd like to share questions from other attendees. Maybe this one from Ross Susanna. How do you use did we use the impact analysis to negotiate the diagnostic test pricing in Georgia? So maybe that's a question for Nino or Natia.
Yes, I can answer the question. So as Alfredo mentioned, so the main purpose of this model was to make it very flexible so that changes can be made at a later stage. So in this case, at the stage 1, we helped government understand what is the current prices, but obviously in the model, we had tools implemented so that they can apply different discount rates. And obviously this is experience in Georgia that when there is a, let's say, large quantity of coverage from the government side, obviously it affects and brings the prices down. So we left this tool to the government to decide how much they can negotiate the prices down, and we made it flexible in the model.
Thank you very much, Nino. I like to maybe go back to the questions from Duncan. Duncan was challenging the 10 years that we were using for the cost estimation, and I like to combine it with another questions from Duncan regarding the evolution of the volumes also. So how can we consider the evolutions of the volumes in the cost estimation, and what is a good time frame to take into consideration for the analysis? Alfredo, Michael?
Yeah, usually budget impact are created to replicate budgeting cycles. So usually budget impact is 3 to 5 years. Rarely is done beyond 5 years. You can forecast and you can try, but usually it's 3 to 5 years. And this is the reason we usually don't include inflation rates into budget impact analysis. You can do, but we do include when doing cost-effective analysis, we discount cost and benefits in the analysis. So again, the two things are complementary. So budget impact complements cost effectiveness, cost benefit analysis, and the assessment of value for money. And budget impact is a tool that you have to really understand how much money. Budget impact analysis is about cash flow. So this is the cash that you need to have in order to pay for the services. Cost effectiveness or cost benefit is not about cash flow, but budget impact analysis is. So this is a big difference. And again, 5 years should be the right, 3 to 5 years should be the right time horizon for VI. The other point, Harold, I missed it. I don't know, Michael, if you want to comment to add.
Evolutions of the volumes?
For the same reason, 3 to 5 years, because this replicates the budgeting cycle, you know? And the volumes over 10 years is unrealistic to predict, but over a budgeting cycle is much more easy to understand. Also, the stability, if you simulate the model many times using Monte Carlo, for example, at short and medium term, the stability of the model absorb much better the uncertainties that we were discussing in this sensitivity analysis than when you do 5 to 10 years of forecast. So this is just a tool, and it's a tool that complements other elements for your decision making. Thank you.
Thank you, Alfredo. Then we have an interesting questions from Yelda Lil. So, sorry for the pronunciation. And I think this question is very relevant for the Georgian context. So how do you control the cost for the private healthcare? So how do you take into consideration the differences between public and private facilities, and make sure that you limit the bias in the model caused by the highest cost in the private facilities?
I can answer the question. So in Georgia, we have, let's say, fully private providers for the healthcare system. And what government does in this case, when they include certain services in their universal healthcare system, they set the limits to the price that they will, let's say, reimburse for such services. So obviously the patients who apply for these services expect the, let's say, higher percentage rate for coverage, and select the providers who can, let's say, where they can receive the full coverage from the government side. So this brings the prices to the levels that government estimates. Here, the important part is that government does not set the prices too low. If healthcare service providers are not able to provide services at the low prices, then there is a limitation to receive treatment for the patients. So this is why understanding the market is important.
Thank you, Nino. One from Lourdes Romero, and maybe it's a question for Michael or Alfredo. How do you negotiate? So in our case, we don't negotiate. So, but how do you obtain the costs from the suppliers so that you can integrate this into the analysis? So so how do you obtain the actual costs of the tests coming from the suppliers? Michael, Alfredo, do you have
Yes. You could look at the cash prices that the providers normally charge for these particular services, and this would be a good estimation of the prices that you expect that will be charged for this particular scheme. But also looking at it from having built the model, having used the various weighted averages, then you're able to estimate the number of patients that will receive care from a given provider. And this will mean that the government, or rather the payer in this situation, will be in a position to negotiate better volume-based discounts. So we could be able to pursue such a direction, given that you already have the data. But the best price would always be what is, let me say, what is currently levied by that particular provider or as cash prices. Thank you.
Another question from Dr. Lucas Niabero regarding the fact that did we consider novel therapies like biologics and the companion diagnostics for this in our analysis, or can we do it in the future? Michael, Alfredo, or Nino?
Well, you can put anything into the model. So actually this is a methodology to create the model. So you can populate the model with whatever is relevant in your context. And again, here what is important is to differentiate cost versus price, and what is the scale of the application of the model. But you can have any type of intervention here. You have to cost, or you have to get the prices. Here also, to complement the previous question, this is all about stakeholder engagement and being a neutral party and being really here in the city or in the context where you operate, trying to help and really trying to improve the services. So getting this type of information is all about stakeholder engagement and building trust and really putting together all the actors and going into one direction. Because many of you are writing in the chat box. Yeah, there is a lot of conflict of interest, especially when private goes with public to provide these services. And you are right. So building this coalition and building this trust is really important. And also, again, we have presented an example for the city of Tbilisi under a very concrete scenario and setting. But think broadly and think that this is something you can use and adapt into other contexts to solve the questions that you have. And also important the perspective of the tool. We can hear the perspective from the payer, whoever has the budget to pay for these services. If you are thinking of investing, then prices don't apply. You have to think about cost. What are the costs of these services? So again, think broader. The tool has been, and the examples that we have explained are limited to one concrete context, but this can be used for many other things. Thank you.
Thank you, Alfredo. I also like to pick one question coming from Bafour, and that is also related to questions we had previously from Samuel regarding the environment. So this tool is not taking into consideration the environment in which it is implemented, meaning do we also take into consideration the fragmentation between public and private sectors, the reality of the services availability of the healthcare workforce? And I think this is a fair question, and it's very well very relevant for SICAN. So Michael, I like to give you the floor to answer that question.
Yes, thank you, Harold. So yes, healthcare systems are fragmented in many settings. So in this particular case, for this particular model, was on the pricing. And this assumed a situation where the payer, in this case, let's call it the government, contracts private or other facilities to offer care, meaning that there is a set price for that particular service. But the reality is that in certain situations, you'll find that some services are offered by the government, others are offered by the private sector. So how could this model work in such a setting? And my proposal would be, you could apply the costing approach where the government is able to estimate the cost of offering each particular service at the public facility levels and be able to integrate it within the model. So instead of the price, we use the cost. And this is for services that are already being offered in the public sector. And this would mean selecting certain services where the government has the economies of scale to be able to offer them at in what I would say a sustainable model. But then there are other tests that the cost of installation of some of these services may be higher, meaning that the government may look at the option of outsourcing these services to contracted private sector providers, meaning that we could also have a model that estimates the utilization of these services by, from the private sector perspective, and the government will be able to reimburse them for services offered. So it could actually be integrated, and that would mean having a new model being made, meaning that for the private sector, you could list certain services, like let's say the government does not have a PET scan. So this could be outsourced to the private sector, and you could be able to estimate the number of patients that will require these services from the cohort which you're following, and able to estimate the cost that will be needed to ensure that this private sector is able to offer these services. So even in a fragmented healthcare system, this could still work, and it will just mean tailoring the model to respond to such a need. Thank you.
Thank you, Michael. I like to add, so the tool was used for the budget analysis for the payers. but here for the sake of this webinar, we are presented it in isolation, but it was not in isolation. I mean, it was part of the city engagement process of SICAN in Tbilisi in that case, in the specific case. And it's built on the needs assessment phase that we've done, where we identify the pain points in the 6 building blocks of the healthcare system. So going way beyond the health financing, we also identify the pain points and address the pain points in healthcare workforce, in service delivery, in governance, in digital health, in access to care, and also in the information system. So we had a long list of solutions that were implemented to address those challenges at local level, and this tool was part of it. We are fully aligned with the comments received in the chat about the fact that this tool will not solve everything, and it needs to be part of a broader engagement in the city to address also the other challenges across the healthcare system. Maybe if I may, I have one question on my side for Michael. It's can we use that tool also for the treatments? So going beyond the diagnostics, is that something that could be done in the future?
Yes, it could be used for that, especially for certain treatments that are easy to predict. I would say radiotherapy. I think that will be easy to model and know the number of sessions that will be needed. But for some like surgery, it might be a little, difficult in estimating the cost unless we have a system where the cost of doing a surgery is already pre-agreed for each cancer. So yes, it will work very well, even for, I would say, inclusion of medicines into a UHC program. It could also work where you're able to model or estimate the utilization of a medicine, the number of patients who will need it, and be able to get the budget impact of inclusion of such a model. So yes, it will work. It's just about the availability of the data to make it work, and also how easy it will be to model some of these scenarios. Thank you.
Sorry, thank you very much, Michael. I see other questions. Yeah, how we able? So yes, to address the questions, because we had this question several times. Yes, we will share after the webinar the recording of the webinar as well as the slide deck. So you will have access to those information. I'm afraid we won't have the time to address all the questions received. Thank you so much for your attention, for your interests, and all the questions that you shared. It's very, very helpful for us. I'd like to move to the closing remarks. So Tim, if you can move to the next slide. I'd like to mention, and it's very important for us, thank you to our technical partners and also to our funding partners, because this is thanks to their support that we can develop that tool and implement it into our cities. So I'd like to extend a special thanks to the Swiss Embassy in Georgia, as well as to Boehringer Ingelheim and Roche for their trust. And also, beyond this specific tool and this specific situation of Tbilisi, for their genuine interest in building coalitions and strengthen the healthcare system where it is needed. So thank you very much to all of you. As you know, the SICAN model is to develop solutions with local stakeholders to address the local challenges. Then we try to scale the impact at regional level and national level. And we also share the learnings with the community so that it's even more meaningful and that so that the community can drive impact beyond the SICAN network of cities. So we were very proud today to share our learnings from BDC and the tool itself. We will gather all those learnings into a how-to guide that we will publish in June, so very soon. And this will be accessible on the website. So please stay tuned and you will have access to the how-to guide. We are looking forward to receiving your comments, your suggestions, your feedback on the how-to guide, because we would like to improve it, especially as we are getting prepared to use it in other cities. So potentially in Arequipa in Peru, in Kumasi in Ghana, and also in León in Mexico, where we are currently conducting analysis of the out-of-pocket expenditures. So this tool could be relevant for also these different contexts. So we are looking forward to improving it. Also, we believe that the tool can be used in other contexts beyond the current network of cities of SICAN. So if you are willing to join forces and to bring that tool to another country, another city, adapt it and use it, please let us know. Feel free to reach out, and we would be happy to work on this with you. So either in the 15 cities that are currently part of the SICAN network or beyond. I will close on this final note and thank you again for your participation, your attendance, and all your questions. On behalf of SICAN, see you next time, and have a nice end of the day.